I'm Xin Yang from the second affiliate hospital of Zhejiang University. I will talk about the unique aspect of coronary artery disease in women. So as we know, sex has a significant influence on several diseases, such as heart failure, coronary artery disease, hypertension, and so on. And as for the coronary artery disease, the prevalence of the prevalence is low in females than men, and also the mortality, even the reduction rate is even the mortality is reduced in both women and men, but the reduction rate is smaller for women than for men. And also, there are sex difference in coronary artery size. A CTA study reveals that women have smaller epicardial coronary artery, and even after adjusting for the age, BMI, and the left ventricle mass. And also, women have the lower disease burden of obstructive CAD compared to men. And for the anatomic characteristics, women also show the smaller left ventricle mass and lower total vessel volume and lower plaque volume and smaller lumen volume. And the characteristic of plaque in women are low risk compared to men. And there is a low ratio of lipid-rich plaque or high-risk plaque. So summary for the sex difference in size from image, we can sum it as a woman have the smaller coronary artery, also have the smaller vessel volume, lumen volume, and also has a reduced ventricle mass and a smaller plaque volume and generally low risk plaque, and also has a low disease burden of obstructive coronary artery disease. So as for the coronary physiology, there are also significant sex difference. So multiple study has showed that women have a higher FFR than men. And also women have the higher resting blood flow. So due to the high resting flow, the woman also had a low CFR and but have the similar IMR. So physiologic and imaging technology also play important role in PCR decision making and PCR optimization. So considering the significant different phenotype of CAD between women and men, so physiology or imaging techniques may play different role in women and men, leading to the different PCR rate and the clinical outcomes. So therefore, previously we conducted a flavor study. In this is an international multi-center randomized study. We enrolled 1,682 coronary artery disease patients with intermediate stenosis. And the study is to head-to-head compare FFR guide PCR and versus IVUS guide PCR. So in the during the 2-year follow-up, we found the MACE is similar between the IVUS group and FFR group, but FFR guide PCR significantly reduced the PCR rate compared to the IVUS group. Based on the flavor study, we analysis the substudy of sex difference in flavor child. So this result has been reported in ESC 2023. We can find women had fewer revascularizations than men, and this difference is mainly contributed by the FFR guide PCR, but not IVUS guide PCR. And also, women had a more favorable 2-year clinical outcome compared to men. And this difference is mainly driven by the deferral of PCR population, but not in the PCR patients. So given reports of the catch-up phenomena, higher downstream revascularization rate after initially low PCR rate with physiology guidance were observed when we doing the further long-term follow-up. So in the extended follow-up of flavor study, we found the revascularization rate in FFR-guided PCR group is significantly higher than IVUS-guided PCR group. So it is important to determine whether this sex-specific difference influences the long-term clinical outcome. And we sought to examine the influence of sex on long-term clinical outcomes based on FFR or IVUS-guided PCR strategy. The primary outcome is target vessel failure, defined as a composite of cardiac death, target vessel myocardial infarction, or target vessel revascularization at 5 years, and also includes a cumulative revascularization rate at 5 years. So this totally 1,753 intermediate lesions were included, and 517 lesions is from women, and 1,263 lesions are from men. And we can find more than 96% patients completed the 5-year follow-up. For the baseline characteristics, women showed old, and for the procedural characteristics, we can find even though the diameter stenosis by visual estimation is similar between women and men, but when we do the QCA analysis, we can find the diameter stenosis by QCA in women is significantly lower than in men. And for the FFR, we can find the woman had a higher pre-PCR FFR, and also woman for the IVUS imaging characteristics, we can see woman had a lower plaque burden and lower area stenosis. So which all of these characteristics was quite similar with the previous studies. So for the long-term clinical outcome, we can find although there are trend that women had a lower TVF at 5 years compared with the men, but there are no significant difference. When we do the landmark analysis at 2 years, we can see the TVF is also the TVF also showed no significance between women and men. And when we look at the TVF in deferred PCR patients, we also can find the lower TVF in, we also can find there are trend of lower TVF in women, but it also no significant difference. Also, the landmark analysis at 2 years also showed that there is no significance between women and men. For the cumulative revascularization rate, we can find women had a lower revascularization rate compared to the men. So when we look at TVF in women, we can see the FFR guide PCR and the TVF in FFR guided PCR and the IVUS guided PCR was similar. Also, the landmarks analysis also confirms this result. And for the cumulative revascularization rate, the FFR guided PCR was consistent. The PCR rate in FFR guided group is consistently lower than that in IVUS guided PCR group. However, when we look at TVF in men, Very interesting, we can find this TVF in FFR guided PCR group is significantly higher than IVUS guided PCR group in men. And also, as a landmark analysis also showed the higher TVF in FFR guided PCR group. So which driven this higher PCR rate, which driven the higher TVF? We can see it's mainly driven by target vessel revascularization, but not by the cardiac death, and the target vessel myocardial infarction rate is similar in FFR or IVUS guided PCI. For the cumulative revascularization rate, FFR guided PCR similarly showed a lower PCR rate compared to the IVUS guided PCR group. So in this sex-specific analysis of the flavor extended follow-up study, we found a woman had a similar long-term clinical outcome, but underwent fewer revascularizations than men. And in men using FFR2 guided PCI showed a high rate of TVF compared to using IVUS. And this was primarily driven by TVR, but not cardiac death or myocardial infarction. And in men, comparable TVF and TVR were shown between the two modalities. The cumulative revascularization rate were consistently low in patients guided by FFR than in those guided by IVUS, regardless of sex. So in conclusion, for the intermediate coronary stenosis, non-aggressive treatment approach guided by FFR or IVUS proved safe in women, and FFR guidance consistently reduced the interventions compared to IVUS in both sexes. So it is particularly effective in women with no evidence of long-term catch-up in adverse clinical events over 5 years. But there's still the challenge for women in coronary artery disease. The woman was underrepresented in most study populations, and leading to a lack of dedicated coronary function study specifically for women. We can see in most of studies, the rate of women is around 25%. So also it is understudied, similar with that in heart failure. So in conclusion, the significant epidemiology, anatomical and physiology disparities exist in coronary artery disease between men and women, and the FFR guide intervention demonstrate particular effectiveness for women. And the future efforts should focus on generating more evidence, developing tailored guidelines, and increasing clinical attention for women with coronary artery disease. Finally, I would thank all the flavor study investigators and all the patient participating in the flavor study. Thank you all. Thank you.